5 seconds. Okay. Good morning, everybody. Buenos días a todos. Muchas gracias por su presencia. Otra vez, continuando con nuestras presentaciones de todos los meses de nuestro profesor invitado por Zoom. En esta oportunidad lo hemos invitado a nuestro querido amigo, el profesor David Diamond, que actualmente trabaja en Rochester, en la Universidad de Rochester, para quien le hemos pedido que nos hable sobre el tema de varicocele, que es un tema bastante interesante y de uso muy práctico de todo el tiempo. Entonces yo le voy a dar la palabra al doctor Diamond para que comience su presentación. Please, David, you can give your presentation. Thank you very much for your presence, and always we are happy to have you here. And welcome to Nuncio, to Anthony also, and all of the professors you have in this meeting. Thank you, David.
Yeah, thank you, German. It's always a pleasure to visit Santa Cruz, even virtually. So this is my pleasure. So this morning I'm going to talk about adolescent varicocele, which has proven to be a very interesting entity to study, and a clinical dilemma. And so we'll talk about that this morning. So varicocele has long been recognized. It was described by Celsus in the 1st century AD, who was the Roman chronicler of medical conditions in his famous treatise De Medicina. And he described varicocele as swollen veins twisted over the testicle, which becomes much smaller than its fellow, inasmuch as its nutrition has become defective. Really a pretty good description. And this is what varicocele looks like in the clinic. You have all seen it. So varicocele in the adult is the most common reversible cause of male factor infertility. We find it in 1/3 of men who attend infertility clinics and undergo evaluation. And the incidence is roughly 15% of all fully developed males. Yet 80% of men with varicoceles are fertile and asymptomatic. And so the dilemma is for the asymptomatic adolescent males whom we diagnose with a varicocele and who have unknown fertility status, can we select those that would benefit from surgical correction? It is a large problem. In a Turkish prevalence study of 4,000 boys, ACB found that the prevalence of varicocele was less than 1% up to 10 years of age, but it grew to 11% in those ages 11 to 19. Steno found that in over 2,000 boys, the incidence was 15% or equal to the adult. This is what we found in our clinic, that the age at which varicoceles began to present took off at about 11 or 12 and peaked at age 14 or 15, and then began to decline as boys progressed toward adulthood, presumably because some of them were referred to adult practitioners. As in many congenital conditions, the milder form of varicocele is more common. So of the 15%, the majority, 9% of the population, are grade 1 varicoceles. Grade 2 varicoceles comprise 4%, and grade 3 varicoceles are found in 2% of the population. But this is not what we see in our clinic setting, because varicoceles are relatively hard to recognize on a routine basis. So in our clinic, we found that almost half were grade 3 varicoceles, and very few were grade 1 varicoceles. Hypotrophy, or impaired growth of the involved testis is very common with varicocele. Acme found it in 9% of his population. Steno found that of grade 2 varicoceles, a third had hypotrophy, and over 80% with grade 3 varicoceles had hypotrophy. What we found in our population was a bit different. We found that a little over a third had no significant hypotrophy, under 10% testicular volume differential, which we felt was within the limits of accuracy of measurement. Over a third also had greater than 20% volume differential, so significant differences, and about a quarter between 10 and 20% differences in testicular volume. Semen parameters are also becoming recognized as increasingly important to assess in the varicocele population. And so for Tanner stage 5 males, the subfertile ranges that we refer to are either the WHO figures in terms of sperm concentration, motility, and morphology, or the National Cooperative for Reproductive Medicine, which has slightly different parameters. But either of those is a reasonable baseline to assess patients with. In our population, in terms of sperm concentration, using either of these guidelines, we found that roughly 15% had abnormal sperm concentrations, shown in orange. A higher percentage had abnormal sperm motility, a little over a third by the WHO criteria, and over 20% in the National Cooperative for Reproductive Medicine criteria. And morphology varied because of the difference in the standards between these two techniques, but with WHO, almost 20% had abnormal morphology, and roughly a third with the National Cooperative gold standard had abnormal pathology, abnormal morphology. And so when we compare varicocele to other childhood urological conditions that we see, you recognize just how large a problem it is. Roughly 0.5% of the population have prenatal hydronephrosis, depending upon your reference standard. Roughly 1% of boys have cryptorchidism, 2% hernia and hydrocele. And if we just include the grade 2 and 3 varicoceles, we're talking about 2 to 6% of the male population that we see in our pediatric urology clinic. And so in management of the adolescent varicocele, our overriding goal should be preservation of fertility. The problem is that in looking at the adult population, 80% of men with varicoceles are fertile. 20% will be infertile. If they go on to have surgery, half of them go from being infertile to fertile. And therefore, we can presume that probably 1 in 10 adolescents will benefit from surgery. And the question is, which ones? The surgical indications for correcting the varicocele in the adolescent that are most common have been discomfort or pain, large size or grade of varicocele, the presence of hypotrophy or testicular disproportion, and the belief that varicocele may represent a progressive disease process that ought to be corrected sooner rather than later. Less commonly, indications include bilateral varicoceles, I should say bilateral clinical varicoceles, ideally, varicocele in a solitary testis, and an abnormal semen analysis, although this is becoming more frequently assessed. With regard to discomfort or pain, we found in our database that pain or discomfort that we could truly attribute to the varicocele was pretty uncommon, about 3 to 4% in our database. It would not be unusual for a boy presenting with discomfort to the emergency room to have an ultrasound that may show a varicocele, but it's important to recognize that the varicocele may well not be the source of pain in that presentation. The highest reported incidence of pain associated with varicoceles was from a surgical series from New York, Claude Reitelman's group, but then New Yorkers may be more sensitive to our pain. In terms of size of varicocele, these series, the New York series by Reitelman, the Tom Parrott and the Darius Paddock series all indicate that it's the grade 2s and 3s that predominate in terms of surgical correction. Very few of our colleagues are repairing grade 1 varicoceles. But it's fair to ask if grade is predictive of outcome. And Dubin and Amelar, who developed the grading system for varicoceles, found that in repair of large versus small varicoceles in the adult, there was no difference in fertility rates achieved. And Steckel found that for infertile men with grade 3 varicocele, there was greater improvement in sperm concentration and motility than for those with grades 1 and 2 who had surgery, but there was no difference in the fertility rates achieved. In a study that we did in Boston that was headed up by Joe Alucal, now in New York, we found that testicular hypotrophy did not correlate with grade of adolescent varicocele. Okay, so what we have here, this is not showing up properly, but on the y-axis, we have, oh, hang on. Let me go back and forward. This is misbehaving somehow, German. I'm sorry.
Don't worry.
Okay. At any rate, what this slide is supposed to show with the bar graphs is that this was grades 1, 2, and 3 varicocele. This was the degree of hypotrophy. And basically, it showed that there was no difference in hypotrophy according to grade of varicocele. There was no correlation in our series. There are problems with testicular disproportion in terms of definition. So some have suggested that there are absolute figures that are meaningful in terms of difference in testicular volume. Podesta suggested that 2 cc's was an important volume difference, and Evan Cass 3 cc's. Tom Parrott suggested that over 10% was significant, and Safan that 25% was significant. And so the definitions of testicular hypotrophy are variable and they're arbitrary. There seems to have been with these no correlation with long-term physiology in terms of semen analysis and fertility. In addition, our tools for measuring testicular volume differences have been variable. So some colleagues have used calipers over the years, some have used rulers. The majority have used orchidometers, either the Rochester or Takahara, which is a series of cut-out blue ellipses. There are 15 in a typical set. The Prater has 12 comparative ovoids. Those are favored by the endocrinologists. And more recently, people have relied on ultrasound calculated volumes with the hope of improved accuracy and reproducibility. And so at Children's, we had done some studies with our radiology colleagues looking at ultrasound measurements of testicular volumes. And this work was done largely by Harriet Paultiel, who was a visitor to Santa Cruz a number of years back, German. And so what Harriet found was that when she did orchidometric and ultrasound measurements of anesthetized dogs, and then calculated true testicular volumes with volume displacement post-orchiectomy using Archimedes' principle, that ultrasound measurements of testis volumes were more precise than orchidometry-generated volumes. And here we have either Joe Bohr or me doing orchidometry in an anesthetized dog, showing how this was approached. And I would suggest that if you do orchidometry in a dog, make sure they're anesthetized. And this was how Harriet calculated true testicular volume. And we found that this argued in favor of using ultrasound. Others have argued that perhaps we should be using orchidometry instead. And so we wanted to compare these two modalities in terms of accuracy. And I'm sorry, this is coming up superimposed, but what Michael Kurtz found in doing 720 measurements of both the left and right testis, and comparing these, okay. Okay, I'm sorry, this is not coming up clearly, German. But what he found was that when he used orchidometry, that the sensitivity in detecting a 20% testicular volume differential was about 1 in 3. The specificity was very good. It was over 90%. But at the end of the day, we concluded that you need to exercise caution if you rely only on orchidometry for evaluation. Orchidometry overestimates testicular size, and there is wide variability. And the sensitivity of orchidometry is modest, such that a 20% volume difference would be missed in 2 out of 3 boys screened with orchidometry alone. In addition, volume discrepancy in adolescent males is a complex issue because we can see volume discrepancy without varicoceles. It can be seen in normals, and normals can experience spontaneous improvement. Even with a varicocele, it may happen in 1/3 to 2/3 of boys. It may vary with the boy's age and Tanner stage, and so it calls into question accuracy and consistency in measurement as well. Mark Sigman from Tony's program in Brown asked the question, is hypotrophy predictive? Again, I apologize for the superimposition, but please bear with me. So Mark studied 611 men with varicocele along with John Jarrow, who was at Hopkins at the time. And what they found was that with greater testicular disproportion, there was progressive worsening of the total motile sperm count. But there was no difference in the hypotrophy versus no hypotrophy groups in mean years trying to conceive, so that the difference, while detectable on semen analysis, was not functionally important. Kirk Pinto found that in adult men with both varicocele and hypotrophy, there was no correlation between the loss of testis volume and fertility status. And so we decided to study the relationship of varicocele grade and testicular hypotrophy to semen parameters in a population of adolescents followed in Boston. Oh, I'm sorry, German. This is presenting. But let me summarize this for you. Let me just see. Yeah, this is. Let me summarize the findings for you. And so what we found was that we grouped patients into go back. So we group patients into three groups based on degree of testicular hypotrophy. We had a group of patients that had testicular volume differences under 10%, a group that were between 10 and 20% volume differences, and a group that was over 20% in volume difference. I'm just going to try and move to a different location here, German, and see if this makes any difference in terms of receptivity.
Okay, no problem.
I don't know. Let me try it. And so we grouped patients according to their volume differential, and we grouped them into three categories. Those with a total motile sperm count that was over 20, considered normal, a group that was in the intermediate range, we called it 10 to 20%, and then a group that were under 10% total motile sperm count. And it was clear in our population of 57 boys that as one went from the under 10% to the over 20%, that the number of normal total motile sperm counts declined and the number of abnormals went up. So that in the over 20% volume differential group, 59% had abnormal total motile sperm count. So this was concerning to us. We also found that there was no correlation in terms of semen parameters with grade of varicocele. So you see here, this is grade. It should be 1, 2, and 3. Sperm concentration, other semen parameters here. There was no significant difference. In a similar study done in Manchester, England, Cervellone and company also found that testicular volume and semen parameters correlated with a 20% testicular volume differential in terms of worse total motile sperm count. So this seemed to be a significant figure. So when we got to 100 patients with adolescent varicocele and semen analysis, we wanted to go back and reassess the effects of the testicular volume differential, as well as total testicular volume on sperm counts in adolescent. And again, this is not coming up clearly. I apologize. But what we found was that a testicular volume differential of over 20% conferred a 2.5-fold increase in the odds of an abnormal total motile sperm count.
Maybe the problem is connection.
Yeah. Yeah. I'm very sorry, German. Let me.
In this way, it's happening all the time. No, don't worry about it.
Okay. I'm just trying to move to see if this makes a difference. But if not, we will carry on. I'm having connectivity issues. My slides are doing very funny things. Okay. Yeah. Okay. So here, so this actually, this is the bar graph. Having connectivity issues, Jackie. So this is the bar graph showing the worst semen parameters. This is your total testicular volume under 30 cc's. So that, along with the testicular volume differential of over 20%, was a poor prognosticator of total motile sperm count. Okay. Okay, so let me carry on. We'll do our best. So we talked about the fact that grade of testicular varicocele doesn't seem to be predictive of fertility status. Testicular volume differential does seem to be predictive. And total testicular volume is also predictive and probably more powerful than testicular volume differential. The important thing to keep in mind is that in a prepubertal male, total testicular volume doesn't help us because those values are based on achieving full development and having a combined testicular volume of over 30 cc's. And so the testicular volume differential gives us some parameter to assess prepubertal males and potentially decide who would benefit from surgery sooner rather than later. Let's talk about the concept of whether adolescent varicocele represents a progressive disease process. There have been 2 Japanese studies that have been regularly quoted to argue in favor of this. One from Okayama, who looked at semen analysis data, but the weakness here was that there was no sequential data of individual patients. It was based on groups of patients and therefore less compelling. The other study that was frequently quoted was from Yamamoto, who actually showed that volume differentials in his series over time were changed relatively little and therefore were of questionable clinical significance. And the semen analysis data was atypical. And this is from the Yamamoto study. And you can see here, you have the untreated group of adolescents with varicocele, the treated group, and the controls. And in terms of volume, the differences are very small. And again, within the realm of accuracy of our measurement tools. In terms of the semen data, you can see we have this indicated as sperm count, capital C, motility, capital M, and morphology, lowercase m, in the 3 groups. And the number that jumps out in the treated group in follow-up was the 73 million in terms of sperm concentration. But this, you can see, is much greater than the control group that was 53 million. And therefore, it raises the question as to what we're really seeing here in comparing treated versus untreated. And I think leaves a large question mark. This is not showing up well, but when we began looking at our group of patients, we decided to stratify them in those under age 15 and those over age 15. And we looked at grade of varicocele in these 2 groups. And you can sort of imagine this was the group 1, group 2, and group 3, and the bars have somehow disappeared. But the height of the bars was very similar, whether patients were younger or older. And so that we found very interesting. And so and we found the same thing for ultrasound volume differential. Take my word for it, the data is not showing up, but we found that big changes were occurring early. And there was really no difference in the percentage of patients with hypotrophy who were under 15 versus over 15. And so we felt that big changes actually were occurring early. And so as a result, it was our belief that there was really no statistically significant evidence of disease progression from early in life to later in life based on the things that we could measure, which were testicular grade, varicocele grade and testicular volume differential. This is another way of looking at it in our population. So we looked at patients undergoing individual patients undergoing 2 sequential examinations. So this shows volume differential on the first exam. On the x-axis, on the y-axis was the volume differential on the second exam. And the green triangles are the patients who improved from one exam to the next, and the red triangles are those who worsened from one exam to the next. And basically what this showed was that it was an equal distribution between the 2 examinations of the 2 population. They were as likely to improve as they were to worsen from their first to their second examination. And so as a result, we felt that it was quite unclear that adolescent varicocele does represent a relentless progressive disease process, and that in and of itself should not be a reason to recommend surgical correction. And so we think that in many ways, the dilemma of adolescent varicocele is analogous to prenatal hydronephrosis. Both of these are frequently diagnosed lesions. Patients in general are asymptomatic. Some children will benefit from surgery, and others may not. Our tools for differentiating these two groups are admittedly imperfect, and so we need to evaluate all apparently meaningful criteria, including semen analysis, and we need to follow patients prospectively. In terms of our population and the percentage of patients that came to surgical correction, we found roughly 21% came to surgery over time, with an age range between 9 and 22 years, with a mean of 16 years. In terms of the surgical indications, volume loss of the involved testis was the most common, and we used ultrasound calculated volumes to assess 20% as a significant difference, or in the postpubertal patient without a semen analysis, a 30% total volume cutoff, beneath that being an indication for surgical correction. And we found that these were compelling values to us because they correlated with distinctly poorer total motile sperm count in our population. This is relatively new data, and this shows a group of boys in our patient population comparing their total motile sperm count pre- and post-operatively following successful repair. So we had only 15 boys that fell into this category. So out of 1,600 patients, 15 had had a total motile sperm count preoperatively and postoperatively, and the majority of these had surgery to improve, with the hopes of improving their semen analysis. And we found that in those who had successful varicocele correction, all but one had some improvement in their total motile sperm count. About half went from having an abnormal semen analysis to normal. And so we felt that this argued for the potential benefit of varicocele correction in the setting of impaired semen parameters. All of these were Tanner stage 5. Let me go back and see if I can pick up the indications. So let me just go through the indications for surgery. It's not, the list is not showing up clearly here, but you know, our surgical indications included hypotrophy that made up the majority of patients. Discomfort was a relatively small percentage, about 6% of our population. An abnormal semen analysis, about 3% of our surgical population. And the fact that the patient was having other surgery, family worries, made up a very small percentage, roughly 1 to 2%. A small number of patients had bilateral clinical varicoceles. This was an indication for surgical correction. And we had one patient who had a varicocele in a solitary testis. And so we felt, as we were seeing more of these varicoceles, that we should look at our surgical results because the optimal surgical treatment of the adolescent varicocele was indeterminate. As you know, a variety of procedures have been described with a variety of modifications, most notably artery sparing and a microsurgical technique. And in all of these techniques, the objective of surgery was to interrupt the column of blood that comprised the dilated spermatic vein and pampiniform plexus. And it was simply a matter of which level, the Palomo being high, Ivanisovich being inguinal, and the microscopic subinguinal approach popularized by Goldstein in New York. And here we see the open approach to the Palomo, where one finds the leash of vessels posterior to the peritoneal fold in the retroperitoneal space. And in the Palomo, there's a mass ligation. One can also identify the testicular artery and spare the artery with a higher risk of recurrence. Here's the Ivanisovich through an inguinal approach that we're all very comfortable with, but where there are multiple venous branches and the risk of failure may be higher as a result. Okay. Okay, and so let me see if I can bring up our results. Is not coming up clearly, but I can summarize them for you. Here we go. So we found that the high open and laparoscopic approaches, modifications of the Palomo, and the subinguinal microscopic had very high success rates, overall exceeding 90%, roughly in the 94% range in those groups. We found that the Ivanisovich was least successful. That had a success rate in the roughly high 70, low 80% range. There was no significant difference in hydrocele rates statistically, in part because of low numbers, but there was a 32% hydrocele rate with a laparoscopic Palomo. Quite high, and this has been shown in other series. And the laparoscopic Palomo had a 100% success rate, but this large hydrocele rate mitigated that. Okay, and so in management of the adolescent varicocele, let me go back. One should bear in mind that it makes sense to be conservative because you will be right in managing these patients 90% of the time. Surgery can be valuable, in particular for those with a demonstrated subpar semen analysis. We've shown that those are likely to improve with surgery, as one sees in the adult population. But one should be selective. And I think I will end it there, German, and take questions. And I apologize for my connectivity issues here.
Don't worry, David. Thank you very much. The presentation, these kind of problems we see all the time, so it is understandable. Okay, no problem.
Okay.
We have some questions here. May I can read for you, please?
Okay.
Well, one question, my question is, which is actually, I remember very well, you were working about surgery by microscopy. So actually, which is your better recommendation?
So I have tried all of these approaches. And I think I have come to the point, German, the technique that I was using in Boston was a retroperitoneal modified Palomo, where I used the Doppler probe to identify the spermatic artery and spared it. And then ligated all of the vessels. I found that I had essentially no hydroceles because we could identify lymphatics, but I had too high a recurrence rate. So my recurrence rate was about 12%. It approximated that of Evan Cass, who who described higher recurrence with artery sparing. So even when I thought I was sparing only the artery, clearly I was having some recurrences. And so I think at this point, my recommendation is to do a laparoscopic mass ligation.
Oh, thank you. We have another question here. Dr. Javier Leal Ojeda, good morning. In cases of varicocele grade 3, which is not possible to obtain some kind of semen, do you realize some kind of hormonal study like HL, FSH inhibin, some kind of test?
So if I'm understanding the question right, German, so a grade 3 varicocele, but inability to obtain semen parameters, then I would base the decision to operate on testicular volume. So if the volume,
do you do some kind of test like LH or EFS?
Endocrine studies? I have not. I have not used endocrine parameters. This was something that Evan Cass described years ago, the LHRH stimulation test. And what Evan found was that he would get normal endocrine parameters even when there were large testicular volume differentials. And so somehow that didn't seem to make sense to me. So I haven't used them in my practice.
Okay. Doctor Guillermo Concha de Chile, un amigo nuestro. He is asking about your conference. Thank you very much.
Sure.
About pain, how do you determine which is the indication? How do you realize what is pain?
Yeah, that's a very good question. I'm glad he asked that.
Or it's a surgical indication.
Yeah, I'm glad he asked that. So over the years, I've come to recognize a pain or discomfort syndrome with varicocele that's fairly characteristic. So that those complaints of varicocele related discomfort are typically associated with prolonged standing that's relieved by lying down. It may be standing, working in a standing position for many hours. It could be long distance runners. And routinely, when they lie down, get off their feet, the pain goes away. It's invariably related to the side of the varicocele. And the majority describe it as discomfort or heaviness. It's the minority who describe it as pain. But it is true that we are referred many patients with testicular pain in whom a varicocele is found, discovered on physical exam or on ultrasound, and it's presumed that that is the cause of the pain. But many times it is not. Many times it is the pain is incidental to the varicocele, and it may simply be benign orgalgia or some other cause. And so in cases where I'm not certain, I wait. I don't recommend surgery, and I observe them longer. And in many of these cases, the pain will disappear.
Okay, thank you. Another question. What about nutcracker phenomenon?
Yes, I mean, the nutcracker phenomenon is, I think that's real. I don't routinely evaluate for it with pressure gradients using ultrasound. If there simply is a varicocele, that's not something that I've looked for. And yet we recognize that varicocele is more common in tall, lean boys with less abdominal fat who may be at greater risk for having a so-called nutcracker phenomenon. But I've not routinely studied for it.
Okay. Dr. Escala from Chile, he asked, any experience with endovascular treatment?
Well, I would say, in our experience in Boston, and it's similar here at Rochester, surgical repair was the first choice for these boys. If they failed surgery, then we would refer them to interventional radiology to study them and give us a roadmap. And usually they were able to embolize a branch that was persistent. If we were referred a failure from elsewhere, we would routinely send them immediately to interventional radiology for study. And their success rate was about 80%. They did well. This was Boston. I don't have as good a feel yet for the track record at Rochester, but in Boston, they did well in salvaging these surgical failures. Obviously, it entailed a radiation dose and so forth, but at the end of the day, they were successful in the majority. Sometimes it took them more than one embolization to achieve success, but by and large, they were quite good. So I have not yet used it as a first line for a presenting varicocele.
Okay. Another question is, we have 2-3 questions more, and I stop it. The next one. How do you explain great volumes, testicular volumes with normal hormonal studies?
Well, I mean, I think that in terms of the hormonal studies, we know that boys with a solitary testis can have normal hormonal function. And so it doesn't surprise me that boys with a unilateral varicocele may have normal hormonal function. I think that what it tells us is that the semen analysis is probably the most sensitive indicator of physiologic testicular dysfunction or impact of the varicocele. And, you know, the hormonal effect of the varicocele, I'd say, remains controversial in the adult world. Some adult colleagues feel that that by fixing the varicocele, one may improve total testosterone. This I think this has been unclear to me, and it's certainly not clear in the adolescent population. But there was a study out of CHOP that Jason Van Batavia published looking at abnormalities in FSH levels in the setting of varicocele. So one can find this in a select group of patients. But as I've interpreted the data, it's not as helpful in terms of determining those who need surgery as semen analysis.
Perfect. The last question is a very long question. I will try to translate. If 20% differential 20% in volume is of diagnosis value, but at peripuberals have difference in volume during the grow up. Do
Yes.
you repeat the clinic test?
Yes, that's a good question. Thank you for asking that. So I didn't make it clear in this talk, but should have, that if a patient presents to our clinic for the first time with a 20% volume difference, let's say they're 14 years old, we would wait a year because there can be spontaneous catch-up growth in testes that are smaller as puberty progresses. And so I think it's important to allow for that, to give the patient at least a year to see if that volume differential disappears. But if the volume differential is distinctly greater than 20% and lasts for more than a year, then I think it's reasonable to correct the varicocele.
Thank you. Anthony wants to say something. Please, Anthony.
David, great job. In spite of the technical issues, I think this talk gets better and better every time I hear it.
Well, thanks, Tony.
I have two quick questions for you. One, if I'm not mistaken, your group in Boston, you published some data on the pre-pubertal varicocele. Could you, and you mentioned it very, very briefly in your talk, any thoughts about whether they should be handled any differently than the post-pubertal varicocele patients, and any concerns that if they present earlier, they may have a more ominous outcome?
Right. Thanks for asking that, Tony. Yeah, I didn't include that data here. At least it didn't show up. So Michael Kurtz did study a group of patients that were prepubertal, and our concern was that it may be more ominous, and that maybe we should be operating sooner on that group of patients. But what we found when we followed them prospectively was that their natural history was very similar to the pubertal patients that presented later in life. So that in essence, there was no difference between the groups at the end of the day. It was just that for whatever reason, they had been diagnosed earlier. And so our conclusion was that even though they're younger at presentation, that there's probably no need to manage them differently.
Great. Thanks very much. That's what I recall from Michael's data. The second
Right.
question, just very, very briefly, is you talk about using testicular volume and total testicular volume as parameters for surgical intervention. But on the other hand, you have good data indicating that it doesn't seem, at least in the adolescent population, that varicocele is a progressive disease. So
Right.
is there any evidence of harm in waiting for a good semen analysis in a Tanner stage 5 patient rather than operating early?
Yeah. Tony, that's the $64,000 question.
Yeah.
And of course, what we were able to look at was whether there was a change in varicocele grade over time, and there seems not to be. The big ones show up early.
Yeah.
Whether there is progressive worsening of testicular volume differential over time, it's a concept that the adults have put out there, but we don't really see it. We see that there are these volume differentials that show up early and seem to persist by and large. That's what we could look at. What we can't look at is progressive change of semen parameters, because it doesn't mean anything to look at a pre-Tanner stage 5 patient. And so all that we know is that a certain percentage of these boys, let's say based on the data that I showed, let's say maybe 10, maybe upwards of 15% will have impaired semen parameters, looking at the total motile sperm count rather than individual parameters. Those patients will have it when you're able to study them, which is at age 17, 18, 19. And we know from the adult data that half of men who are infertile with varicoceles are not salvaged by surgery. And so the question is, if we operated on those boys who show up with abnormal semen parameters earlier, could we have done better for them? And we don't know the answer. So that really remains the question, and the reason that we have looked for other indications for surgical correction.
I think it makes sense, David. And then again, thanks for a great talk. I look forward to hearing it again in the future.
Thanks, Tony. I look forward to seeing you again in the audience, as always.
Thank you very much, David. Thank you, Tony. Thank you, everybody, for coming to be with us. Your great presentation was, as always, great. Thank you, David.
Thanks, German, and my apologies for the technical issues this morning.
I will speak in Spanish. Para el próximo mes tenemos como invitado al doctor el 1 de septiembre, septiembre, al doctor Dennis, que va a hablar sobre tumores suprarrenales. Y posteriormente tenemos el día 24 o 25, si mal no recuerdo, al doctor Rink, que va a hablar sobre reparaciones en pacientes con DDS. We appreciate your presentation. Again, thank you, David. Okay, and gracias a todos por...
Be well, everybody.
Hasta la próxima oportunidad. Bye, David. Thank you very much.
Bye, German.
Thank you, Tony.
Take care. Good to see everyone.